Bismillahirrahmanirrahim. Assalamu alaikum. Um, I welcome you all today to the lectures regarding the heart abnormalities. And one of the abnormalities related to heart is arrhythmias. Now, today we are going to learn about what are their causes, what are the classification, what actually happens during their course. So, the cardiac arrhythmias have different causes. There can be abnormal rhythmicity of the pacemaker. There can be the shift of pacemaker from the physiological pacemaker, which is the sinoatrial node, to another place in the heart. Blocks at different points in the spread of the impulse through the heart. Abnormal pathway of impulse transmission through the heart. Spontaneous spurious generation of impulse in almost any part of the brain, of the heart. Now the classification, broadly it is classified into the arrhythmias with abnormal sinus rhythms and the arrhythmias with abnormal rhythm that result from block of heart signals within the intracardiac conduction pathway. So the first classification, abnormal sinus rhythms, they are having the types like tachycardia, paroxysmal tachycardia, atrial, ventricular tachycardia, bradycardia, carotid sinus syndrome, sinus arrhythmias. Then the second type, that is the abnormal rhythm, which results from the block of heart signals within the intracardiac conduction pathway. That is the sinoatrial block, atrioventricular block, incomplete heart block, first degree heart block, second degree heart block, third degree heart block, and complete heart block. Stokes-Adams syndrome, incomplete intraventricular block. Now, what happens if there is sinus tachycardia? The heart rate can be like 160 beats per minute. The causes can be if there is increased body temperature, if there is stimulation of heart by sympathetic drugs, toxic conditions of the heart, hypotension, acute hemorrhage, chronic anemias, pulmonary embolism, thyrotoxicosis, prolonged debilitating conditions, pericarditis, acute rheumatic fever, abnormal rhythm. Sinoatrial block. The impulse from the sinus block is blocked before it enters the atrial muscle, and so the ventricles they pick up a new rhythm. You can see the ECG strip if there is the presence of sinus tachycardia. There is increased heart rate with normal gapping in between them. The same gapping is there. The sinus bradycardia. If the heart rate is below 60 beats per minute, the person is said to be suffering from bradycardia. Number one, it is there in the athletes. Why? Because the heart size is stronger and larger than that of normal person. Physically trained persons, parasympathomimetics like acetylcholine, methacol, sympatholytic drugs, vagal stimulation of heart, any circulatory reflex stimulating the vagus nerve causes release of acetylcholine at vagus nerve endings in the heart, carotid sinus syndrome. See, the strip of ECG will show such rate. Then sinus arrhythmia. If the rate is between 45 to 100 beats per minute, the P wave is showing the rhythm is sinus, the QRS is normal, the conduction is normal, but the rhythm is irregularly irregular. The rate usually increases with inspiration and it decreases with that of expiration. This point is very important. What happened to heart rate during the course of inspiration and expiration? That is, it increases with inspiration and it decreases with expiration. This rhythm is most commonly seen with the respiration due to fluctuations in the vagal tone. The non-respiratory form is present in diseased hearts and sometimes confused with sinus arrest, and is also known as sinus pause. Sinus arrhythmia. It is more common in children and youth. The pulse rate is usually slow, shows irregular rhythm, which is of respiratory type, in which the heart rate is going to increase during inspiration and decrease during expiration. There is non-respiratory type of sinus arrhythmia. It is not related to breathing. The causes can be morphine poisoning, digitalis toxicity. The cause is vagal tone increases and produces slowing of heart rate. See that this is having irregular behavior. Sinoatrial block. Impulse from sinus node is blocked before it enters the atrial muscle. ECG changes show that there is sudden cessation of the P wave. The QRST complex is slowed down. Ventricles, they pick up the new rhythm. The impulse usually originates spontaneously from AV node. Then we have the AV block. The rate is normal or bradycardia. The P wave, those present are normal. The QRS is normal. The conduction is normal. The basic rhythm is regular. In a type 1 sinoatrial block, the PP intervals is shortened until one P wave is dropped. In a type 2 SA block, the PP intervals are an exact multiple of the sinus cycle and are regular before and after the dropped P wave. This usually occurs transiently and produces no symptoms. It may occur in healthy patients with increased vagal tone. It may also be found with coronary artery disease, inferior myocardial infarction, and digitalis toxicity. Now, what are the causes of atrioventricular block? There can be ischemia of AV bundle. There can be compression of AV bundle by scar tissue or by the calcified portions of the heart. There is inflammation of AV bundle, may be caused by myocarditis, diphtheria, or rheumatic fever. If there is extreme stimulation of heart by the vagus nerves and is seen in carotid sinus syndrome. Incomplete heart blocks. All or some impulses manage to travel from SA node to the ventricles. It is of two types, that is the first degree AV block and the second degree AV block. In the first degree AV block, there is usually a slight delay. ECG changes, they show that there is prolonged PR interval and which is of 0.20 seconds. First degree AV block, the rate is variable, P wave is normal, QRS is normal, conduction. The impulse originates in the SA node but has prolonged conduction in AV junction. PR interval is 0.20 seconds and the rhythm is regular. This is the most common conduction disturbance and it occurs in both healthy and diseased hearts. Now, first degree AV block can be due to inferior myocardial infarction, digitalis toxicity, hyperkalemia, increased vagal tone, acute rheumatic fever, myocarditis. Interventions include treating the underlying cause and observing for progression to a more advanced AV block. Second degree heart block. The conduction through the AV bundle is slowed enough to increase the PR interval, that is 0.25 seconds to 0.45 seconds, and the ECG changes, they show atrial P wave, no QRS, T waves, dropped beats, rhythm is like 2 is to 1, 3 is to 2, and 3 is to 1. Then we have the second degree AV block, that is Wanky back type, which is Mobitz type 1. Wanky back block. The rate is variable. The P wave normal morphology with constant PP interval. QRS is normal. Conduction, the PR interval is progressively longer until one P wave is blocked. The cycle begins again following the blocked P wave. The rhythm is irregular. The second degree AV block type 1 occurs in the AV node above the bundle of His. It is often transient and may be due to acute inferior MI or digitalis toxicity. Second degree AV block or Mobitz type 2. The rate is variable. The P wave is normal with constant PP intervals. QRS is usually widened because this is usually associated with the bundle branch block. Conduction is PR interval may be normal or prolonged, but it is constant until one P wave is not conducted to the ventricles. The rhythm is usually regular, and this block usually occurs below the bundle of His and may progress into a higher degree block. It can occur after an acute anterior MI due to a damage in the bifurcation or the bundle branches. It is more serious than the type 1 block. So, see the second degree AV block, Mobitz type 1. See second degree AV block, Mobitz type 2. Third degree or complete AV block. The atrial rate is usually normal. The ventricular rate is usually less than 70 beats per minute. The atrial rate is always faster than the ventricular rate. P wave is normal with constant PP intervals but is not married to QRS complexes. QRS may be normal or widened depending on where the escape pacemaker is located in the conduction system. Conduction, atrial and ventricular activities are unrelated due to the complete blocking of the atrial impulses to the ventricles. The rhythm is irregular. Complete AV block of the atrial impulses occurs at the AV junction, common bundle or bilateral bundle branches. Another pacemaker distal to the block takes over in order to activate the ventricles or ventricular standstill will occur. May be caused by digitalis toxicity, acute infection, myocardial infarction, degeneration of conductive tissue. Stokes-Adams syndrome. In AV block, some impulses are conducted from the atria into the ventricles, but some impulses are not conducted. The usual cause is ischemia of the conducting system. Override suppression. Each time the atrioventricular conduction ceases, the ventricles often do not start their own beating until after a delay of 5 to 30 seconds. So we should be knowing about this term override suppression, which occurs like after delay of 5 to 30 seconds. After few seconds, the ventricular activity has been suppressed and then distal portion of the AV node becomes ectopic pacemaker. Stokes-Adams syndrome. It acts as a pacemaker of the ventricles called ventricular escape. The brain cannot remain active for more than 4 to 7 seconds without blood supply. Some patients they faint after few seconds, and this periodic fainting spells are called as Stokes-Adams syndrome. Premature contraction is a contraction of the heart before the time that normal contraction would have been expected. This is also called as the premature beat, extrasystole or ectopic beat. Causes of premature contractions: ectopic foci due to local areas of ischemia, small calcified plaques, toxic irritation of AV node or Purkinje system or myocardium due to drugs, nicotine, and caffeine, cardiac catheterization, premature atrial contractions. Premature atrial contractions when the atriums contracts very fast. P waves occur too soon and PR interval is very short. The possible reason is that the beat originates in the atrium somewhere distant from SA node. Atrial premature contractions arising from somewhere is either the left or the right atrium. The cause can be rheumatic heart disease, coronary artery disease, hypertension, hyperthyroidism, hypokalemia. The interval between the premature contractions and next succeeding contraction is called as the compensatory pause. Premature atrial tachycardia. The ECG changes. P wave occurred soon and PR interval is shortened. Pulse deficit. The pulse wave passing to the peripheral arteries after a premature contraction may be so weak that it cannot be felt in the radial artery. The atrioventricular nodal or AV bundle premature contractions. AV nodal premature contractions. The cause can be the cardiac impulse traveled back into atria at the same time that it traveled forward into the ventricles. The ECG shows the missing of P wave. P wave is superimposed onto the QRST complex. Premature ventricular contractions. Prolonged QRS complex because the impulse is conducted through the muscles of the ventricles. Premature ventricular contractions. High voltage QRS complex. The normal impulse passes through the heart. It passes through both the ventricles, but when premature ventricular contraction occurs, the impulse always travels in only one direction. One entire side or end of the ventricle is depolarized ahead of the other, causing large electrical potentials. Premature ventricular contractions causes cigarette smoking, coffee, lack of sleep, emotional stresses, pathological causes, ischemia. Premature ventricular contractions result from the re-entry mechanism or signals that originate from the borders of infarcted or ischemic areas by re-entrant mechanism. Paroxysmal tachycardia. Most paroxysmal supraventricular tachycardia is due to re-entrant mechanism. The incidence of paroxysmal tachycardia is higher in AV, or you can say the atrioventricular node re-entry tachycardia and atrioventricular re-entry tachycardia. The most common is atrioventricular re-entry tachycardia, that is in the 90% cases. It occurs in any individuals, usually no structure heart disease. Then we have the atrial paroxysmal tachycardia. The abnormal focus lies within the atrium, often result from the aberrant rhythm involving the AV node. It is more common in the young, healthy individuals and is called as the supraventricular tachycardia. Ventricular paroxysmal tachycardia. It is a serious condition because it only occurs if considerable ischemic damage is present. It initiates the lethal condition of ventricular fibrillations. Drugs like quinidine and digitalis causes irritable foci that lead to ventricular tachycardia. And this is all about today's lecture regarding the arrhythmias related to heart. So stay blessed and Allah Hafiz.